A'udhu billahi minash shaitanir rajim. Bismillahir Rahmanir Rahim. CME Update by Dr. Tariq Masood Khan, Obs Gynae Family Emergency Specialist, Gulf KSA internist, working now as district gynecologist. Update by Mother and Child Survival Group of Pakistan. The CME review is recurrent miscarriages. The recurrent miscarriage is defined as 3 or more consecutive spontaneous miscarriages which may or may not follow a successful birth with the same biological father. Its etiology is related to the increased maternal age, and half of these is unexplained. There are various causes attributed to this recurrent miscarriages, which are first trimester miscarriages but can have the element of mid-trimester one, which is having a late miscarriage due to infections like bacterial vaginosis and cervical incompetence and cervical weakness. Painless dilatation of the cervix in second trimester. The causes attributed to this are: number 1, antiphospholipid syndrome. This is basically having due to anticardiolipin antibodies IgG, IgM, and anticoagulant antibodies with 2 weeks apart in a patient with miscarriages, 3 or more miscarriages in first trimester, 1 miscarriage at 10 or after that, and a birth of an child 34 at less than 34 weeks with history of preeclampsia and pregnancy-induced hypertension and eclampsia. This is antiphospholipid syndrome. Then there are genetic causes. Genetic causes in the partner carries, the parents carries, have mutation, genetic mutation, either with Robertsonian reciprocal or Robertsonian translocation. They have got the genetic parental karyotyping abnormalities which may run genetic mutations. Then come the anatomical abnormalities. Anatomical abnormalities are congenital abnormalities of the uterus like septate and septate uterus and arcuate uterus, and septum of uterine septum abnormalities, as well as these congenital abnormalities may have their association with recurrent miscarriages. Fibroids, intramural and submucal fibroids, are known to be causative for the recurrent miscarriages, though their role is still debatable. Genetic causes, and then thrombophilia screen. Thrombophilia screen, pregnancy is a hypercoagulable state, and there are protein S and C deficiencies, and there are other deficiencies of thrombophilias, uh, which leads to increased chances of these microthrombi development and leads to these recurrent miscarriages. Protein C, protein S, prothrombin 2, and other various abnormalities of thrombophilias. Then there are fetal chromosomal abnormalities, and that also is related with the increase first trimester miscarriages. Then comes the endocrine, this thyroid, hyperthyroid, hypothyroid, thyroid antibodies, and diabetes, and PCOS, polycystic ovarian disease, have been associated, but still there is no proven fact about them. Infection, bacterial vaginosis is used to be the cause of recurrent first trimester miscarriages, and also proven definite second trimester miscarriages. BV, bacterial vaginosis. And then other causes are also there, like torch studies, and their other, but their role not yet defined. And then the role of endocrine is not proven, and the role of infection, proven infection of BV in second trimester, and then there are immunological causes, but for that they are still hypothetical, as no link between natural killer cells and uterine killer cell have been associated. So these are one of the very few and important causes mentioned. Now they're related to their investigations. We have to have cytogenetic analysis of the product of conceptions, ultrasound, transvaginal ultrasound, thrombophilia screen, and cervical weakness in the second trimester, and anticoagulant antibodies, and cardiolipin antibodies, IgG, IgM, and 2 weeks apart, and DVR, DVVRT, and APTT. With the TVS and the abdominal ultrasound, the septums of the uterus, uterine septums, and fibroids, intramural or submucosal, and septate or cornuate uterus, they are identified. Endocrine screen for these thyroid, antithyroid antibodies, and hyperprolactinemias, and others have not still any definite association, and similarly diabetes also. Though these have been implicated previously, but still the things are being sorted out. Then comes the infective causes for the recurrent swabs in the second trimester and first trimester for bacterial vaginosis. And for the torch studies for toxo, rubella, herpes, HIV, but there is no proven association. And then we have to have paternal karyotyping for genetic referral for both maternal and for maternal paternal genetic mutations, and then comes the uh, fetal chromosomal abnormalities, especially they are with in they are incompatible with life, and they are in the first trimester. Now, the management depends upon the cause. As I have told you that 35% of these are have by chance they have miscarriages, and so they fall into unexplained group. And the best thing about this is that 75% of them will have successful next pregnancies. So no direct intervention advised except to follow in early pregnancy antenatal dedicated units. Similarly, the recurrent miscarriages are also advised to follow the dedicated antenatal units. For the detection of fetal chromosomal abnormalities, for them they have to be referred to geneticist, genetic counselor, fetal medicine specialist. And then about the paternal karyotype is necessary. Paternal and maternal karyotype both are necessary for to sort it out the genetic mutations. For the this septum abnormalities and this uterine septate or cornuate uterus, they have to be done in a very highly selected cases. And then about the intramural and also submucosal fibroids, they are also in highly selected cases. After a after a time given for their assessment and consideration. Then comes the uh, for genetic causes, paternal and maternal karyotype is to be done, and for fetal medicine specialist, this fetal chromosome abnormality have to be referred to this fetal medicine specialist, genetic counselor. And then for thrombophilias, most important thing is to have a thrombophilia screen, and then we have to do all these to find out the deficiency of protein C, protein S, prothrombin and others, and then has to be rectified accordingly. And then antiphospholipid syndrome, the most important is to find out, to detect anticardiolipin antibodies and to detect anticoagulant antibodies 2 weeks apart. And then they have got the best treatment implications, and then they are given with 40% improvement with loperin aspirin 75 milligram, and 70% improvement with the combination of aspirin and heparin. And that has to be started as soon as the fetal heart activity is detected. It is started right from the first trimester and goes up to the late third trimester, and this gives a 40% with aspirin alone and 70% with aspirin and heparin combination. So a very successful outcome with it. With the bacterial vaginosis, we have to sort out these swabs in the first trimester and especially in the second trimester, recurrent swabs, and then we have to consider prophylactic rotating antibiotics like clindamycin, amoxicillin up till third trimester. This association with diabetes with thyroid, with PCOS have not still yet proven. And similarly for the torch. So best thing is for recurrent miscarriages, and especially with the unexplained group, which is 35% and have the 75% successful outcome. They need to be followed and given support in the early pregnancy, dedicated antenatal units, and has these facilities of testing and all these with the genetic mutations and fetal medicine specialists. Then the causes with the role of steroids, especially in the antiphospholipid syndrome, has not been has not been proven. Rather, it increases the morbidity in both maternal and fetus, and this should not be the sole indication for their use. But if there is another indication, that is something else. But it is not advised except aspirin and heparin in anticoagulant in this antiphospholipid syndrome. Then there are other things which, as I have mentioned, which are only on trial basis. And these are estrogen and progesterone supplementation, and paternal white cell immunization, estrogen and progesterone, HCG, vitamin supplementation, trophoblast cell membrane infusion, intravenous immunoglobulin. They are all only on trial basis as to have their effect in immune-based causes of the recurrent miscarriages. So we will come with another review. Takeaway message is pray, praise, trust, love, follow Asue Hasna sallallahu alayhi. Pray, praise, trust Allah always, and follow Asue Hasna sallallahu alayhi wa sallam, our health and survival. And we must not forget our glorious past. दो नीम इनकी ठोकर से सहरा व दरिया, सिमट कर पहाड़ इनकी हैबत से राय. And also very important is to always pray and talk and worship Allah, ask anything from God Almighty Allah. हम तो माइल बकरम है, कोई साहिल ही नहीं, राह किसे दिखलाएं, राह बरे मंजिल ही नहीं. So हस्बुल्लाह व नेमुल वकील, नेमुल मौला व नेमुल नसीर. Allahumma ajirna minan nar, save us from the fire of Jahannam. And Allahumma zikrak, shukrak, husn ibadat. Ala bas zikrallahi tatmain qulub, wa kufa billahi waliya wa kufa billahi nasira. Thank you very much. Best of luck, and we'll come with another view. Wama alayna illa al bala.